So we will do a quick recap of the fee-for-service payments before we go into capitation. So as we remember, the fee-for-service has three types: cost-based reimbursement, charge-based reimbursement, and prospective payment. In the cost-based reimbursement, the payer basically pays billed or gross charges for services. The reimbursement is limited to allowable cost only, but there is a guarantee that the provider cost will be covered. For the charge-based reimbursement, payers pay bill charges according to the charge master. The charge master is basically a list saying this is the service and this is the bill. In this one, payers are at the mercy of providers in regards to the cost of services. Now they pay discounted and negotiated charges. Earlier they were not doing that, but now they pay discounted and negotiated charges. And in the prospective payment, the rates are established by payers before the services are offered, and it can be in the per procedure, per diagnosis, per day, or bundled payment. Okay, so the next one is capitation, where providers pay a fixed amount per covered life per period, regardless of the amount of services that are provided. Payment is not really tied to utilization but to the number of covered lives. Payment to providers is made on a per member per month basis and used primarily by managed care plans. The impact of capitation will be examined throughout in the course. Medical code, I'm sorry. Medical coding is the first step in the reimbursement process. Coding is performed by administrative personnel based on clinicians' notes. There are three different types of codes that are commonly used by providers: ICD codes, CPT codes, and another one is HCPCS codes. For the ICD codes, the codes are used to specify diseases, symptoms, or injuries. The codes currently consist of 3, 4, or 5 digits. So, for example, if the code has like a .0 or something, that means it is more detailed information. For example, 410 alone means heart attack or cardiac arrest, but 410.0 means that there is a cardiac arrest, but on the anterior wall. ICD codes are used by hospitals to specify inpatient diagnosis. ICD-9 was used up until October 2015, but ICD-10 has more longer codes, 3 to 7 characters, and that is now required. The current procedural terminology codes are also called as CPD codes, and these codes are 5 digits. For example, 99211 is a simple short office visit, 99215 is a complex long office visit. CPT codes are used by physicians and other clinicians to specify procedures performed on patients. Now there are some Medicare reimbursement methods. Different methods are used for different providers. Most use a method of classifying patients into groups based on clinical data. Patient groups are weighted to reflect different use of resources, and with the weights in which the weights are frequently updated. So we'll illustrate three examples. More information can be found at the Medicare Payment Advisory Commission website. Hospital acute inpatient services is the one of the first one. The inpatient prospective payment system is used. Patient's diagnosis at discharge, patient's condition and treatment, and their market conditions and hospital geography, all of that are used for inpatient prospective payment system used by Medicare. And then each discharge is assigned to a Medicare severity diagnosis related group, and payment rates are calculated using a base dollar amount, first adjusted for local input prices, and then it is multiplied by the MSDRG relative weight. Physician services in physician fee schedule is used. Each service has a relative value unit that is assigned that reflects amount of physician work, practice expenses, and liability insurance cost. That includes skill level, training, intensity, and time required for service, equipment and supplies cost, and cost of malpractice expense, which is the relative risk and potential malpractice claims. Payment rates are calculated using an RVU value, first adjusted for local input prices, and then it is multiplied by a standard dollar amount, which is the conversion factor, and the provider is paid flat amount minus the coinsurance. So, health reform and reimbursement methods. There has been an emphasis on value-based purchasing. The Medicare initiative says it provides incentives for high-quality care to Medicare beneficiaries. Hospitals are rewarded for their performance compared to their own or compared to other hospitals. There are new models of bundle payment. There is a single sum that will cover all healthcare services for example, which are related to a procedure. For example, a bundle payment may be made for all obstetric services that are associated with the pregnancy, provided by a single physician, including all prenatal and postnatal visits, as well as the delivery. Then there is a shared savings programs, reduce healthcare spending, receive a reward in the form of portion of savings. Then there is a quality-based clinician compensation, where there is a shift in medicine from volume-based focus, and there is you can earn additional compensation based on the quality of care. Also, the readmission reduction program, where you have financial penalties if a patient leaves your hospital and comes back to your same hospital within 30 days of discharge, then there is a financial penalty. And then there is program to reduce hospital acquired conditions, which is focused on improving patient safety. And there is also a 1% penalty for if you have injuries, falls, and infections.